Thank you, Kay. And thank you, everybody. Good morning. I hope you are all awake and get something out of this talk. I'm going to talk about two technologies. One is for the front of the eye for a dry eye syndrome and a new drug. And the other one, and this first part will also show that from the front of the eye you can get drugs back in the back of the eye in the retina. So that will be the first part, and the second part will be a new polymer which can provide long-term release in the intravitreal space, so intravitreal injections, which can give you 4 to 6 month delivery. With that, so those two technologies. So as I mentioned, we are going to look at the target area. One is in the front of the eye, on the surface of the eye, and then you'll see that that drug will go through the side of the eye into the back area, the retinal area, and the other one is the intravitreal injection. So 3 drugs I'm going to talk about for the front of the eye, and these are all hydrophobic drugs, very water insoluble. One is a voclosporin, which is a derivative of cyclosporin. It's even much more hydrophobic than cyclosporin. And it's a calcineurin inhibitor. It is going into clinical trials for dry eye syndrome. And dexamethasone steroid for the uveitis. And rapamycin, an mTOR inhibitor, which is can be used for the treatment of AMD and choroidal neovascularization. So I'm going to talk about these 3 drugs. The formulation that we do is a novel nano-mixed micelle preparation, which has we have patented. We have an issued patent now on this preparation, and as you will see that it produces clear aqueous solution. You do not need any oil or emulsion or any other fatty material to dissolve these drugs. So this dry eye is a very large and growing problem. Right now there is only one drug available in the United States, that's Restasis, and that's a cyclosporin emulsion 0.05%. And this is caused by the chronic inflammation of tear-producing lacrimal gland, breakup tear film, blurred vision, corneal damage, and pain. And the risk factors are also LASIK, menopause, and autoimmune disease. So it's a significant medical need, and current therapy, as I mentioned, that there is some artificial tears, and also Restasis is available. And one subset is Sjogren's, which are dry eye, dry mouth, inflamed joints, 1% of the population, and they all are candidates for dry eye syndrome. This is the next generation drug that I'm going to tell you about, the calcineurin inhibitors, voclosporin. It downregulates the pro-inflammatory Th1 cells, and it has gone into some clinical trial for psoriasis, uveitis, and renal allografts, and we were using this drug to develop dry topical ophthalmic formulation, aqueous clear solution. So this is going to be used for dry eye, blepharitis, and conjunctivitis. It's a designed novel molecule. It has a 4 times greater potency versus cyclosporin, predictable dosing, and extended therapeutic window. So we expect that it will have high efficacy, good safety, suitable for chronic form of dry eye. So let's go into the structure of the if you know, this is the cyclosporin structure. Yeah, if you look at the cyclosporin, there is a groove here in the side chain, and to this is attached another vinyl group. And you'll see that attaching a small change, a vinyl group, it increases the potency of binding to cyclophilin. And I'm going to show you in the next slide that this is a higher affinity to calcineurin than cyclosporin A, because you can see that this latch that comes with the vinyl group, and that actually fits better into the receptor, calcineurin receptor. So that's why this is much more potent than cyclosporin. And what we did was we made a formulation which you make a cage. And to make the cage, we used 2 different polymers. One is called vitamin E TPGS. You can see the red part is the vitamin E, and this is a very hydrophilic part because it has many hydroxyl group and oxmethyl group which can form hydrogen bonds. That's how this part solubilizes, is very water soluble, and this part is very lipid soluble where the drug can come in. But if you just make one polymer, it is not very stable micelle. It falls apart at room temperature. If you look at another moiety that we used is the octoxinol 40, which also has a hydrophobic group here on this side, the red side. And also here you have the 40 of these groups, which are very well hydrogen bonded with water. So when you put them together, it kind of sandwich micelle that is formed, and that stabilizes the whole structure. So it is very stable. And here it is, this forming is, if you look at the TPGS and then you add these are monomers, and you can see that in the structure, this is both of them, the hydrophobic part of octoxinol 40 and the vitamin E part of TPGS, they come all in the middle. So this is a very hydrophobic pocket. And you can see outside is all the green, which are all water-soluble groups. So that's how, if you take a drug, hydrophobic drug, it will go inside the micelle, and it will be solubilized because of this water-soluble groups, hydrogen bonding with water. So this is the structure. Here you can put any hydrophobic drug like tacrolimus, sirolimus, dexamethasone, and in this case voclosporin. And we made this. So you have the vitamin TPGS, and then the blue is the octoxinol 40, two different surfactants. And if this is a brick, this is a cement. So it makes a very tight micellar structure so that it is solubilized. And it is solubilized because of the hydrogen bonding that happens with the water. So the drug is solubilized. And here you can see the structure here. You can see these are very small nanomicelles. These are usually 12 to 25 nanometers. Okay, thank you. So these are 12 to 25 nanometers. It has a very low polydispersity, so very uniform nanostructures, and viscosity is like water. And if you see that the dissociation temperature, that is due to, if you go above 60 degrees, it will fall apart, and you can see that now micelles break down and the drug is again precipitating. But as soon as you go below 59, again you'll see that the drug is forming, going into micelles and solubilized. So you can go back and forth thermodynamically above and below the temperature, and then you can make it solubilized or unsolubilized. And the regeneration time in this case is 3 minutes. It will form micelles again and go into solution. Here is the structure. Now what happens is if you have a drug like a rapamycin or a voclosporin, this is solubilized, and then when it comes in terms of the lipid bilayer, like a tissue, what it happens is forms reversal. The micelle reverses because the lipid layer wants to is unstabilized by these hydrophilic groups. They want to go inside, and you can see that the red part goes outside, then the green part goes inside. So it's a reverse micellization, and that pushes the drug from the solution into the tissues. So the data shows that it's a very high concentration is produced in the lacrimal glands, meibomian glands, wherein the drug needs to be, and then it stays in the lipid layer in the tissues for a longer time. Here the distribution of the ocular distribution of dexamethasone, sirolimus, and voclosporin in anesthetized rabbits after single topical drop administration. You can see that with dexamethasone, we get a very high concentration in cornea, iris, ciliary, sclera, and you can see in this case the retina-choroid is a very high concentration. Aqueous humor, lens has no drug in it, and vitreous humor nothing. So for all of them, if you look at dexamethasone, sirolimus, voclosporin, similar results we have obtained. Very high concentration in the back of the eye and the sclera and iris ciliary, but nothing we are seeing in terms of lens and vitreous humor. that could be an advantage because we know that dexamethasone and other steroids, if you're giving by implants or any other delivery systems, there is a lot of drug that goes into the lens and vitreous humor, causing cataract and other inflammatory responses in the back of the eye. And so this could be a method to deliver drugs from the topical drops to the back of the eye and get therapeutic concentrations. So why it is more into the back of the eye, why it is not, how it is going. We are not seeing anything in the vitreous, anything in the lens. So that means if we have the corneal route, then from the aqueous chamber, there you'll expect the drugs to go into the vitreous and into the lens. But what we think, by the systemic route, we don't think it is going into the systemic administration because in the systemic levels are very low. You don't see much drug in the blood circulation. So this must be going through the conjunctival scleral route. So it is going through conjunctiva, we get high concentrations, sclera, and then from the sclera going through the into the posterior tissues, including RP and vitreous. And vitreous it doesn't because the drug is very hydrophobic. Once it comes from the back into the retina, it does not partition from the retina and RP back into the vitreous humor. So it stays in the tissues at a high concentration over a longer period of time. So that is the better way of delivering drugs than into the back of the eye than trying to push it through the lens and the aqueous and the vitreous to get it into the retina. So this is a schematic representation. What we think is happening is the drug inside the micelles can go through the scleral pathway, aqueous channels, and once it goes in there into the choroid, it protects, the micelles protect the drug because otherwise the choriocapillaris and both the lymph circulation, the blood circulation can take a lot of this drug. That is one of the major problems of delivering drugs into the back of the eye because of not the static barrier, not these membranes, but it is mostly the circulation in the choroid that causes the drugs to be lost. So I think that there is some amount of protection because micelles is very hydrophilic outside, water soluble, and it goes through the channels and then releases the drug near the Bruch's membrane, and that's where your target is for AMD and DME. Bruch's membrane and RPE. So now we did this drug went into rabbits and very toxicity study and the tolerability studies we did in the rabbits, and then it also went into phase 1 clinical trial. So as you can say that we did various concentration. We can go up to 0.2 or even 0.5% of voclosporin, which is 3 to 4 times less soluble than cyclosporin. So we can get very high concentration of a hydrophobic drug using these micelles. And you can see the pretreatment 1 hour, all of these formulations is very low. But here you can see that restis is pretty high. Okay, so these are the studies. Restesis, and the tissues, as you can see that once the tissues get high concentration, they stay for a long period of time. And you can see that we get a very high level in choroid retina, we get in lacrimal gland, submandibular gland, whereas in case of restesis, this is below the therapeutic levels, and we do not see much in choroid retina. So these are the very important things, and I have to go through another one that I started, pentablock polymer for the back of the eye intravitreal injection. There's a new polymer. This has also been patented. We have issued patents on this. And we can make 5 blocks that can vary molecular weight and block length, and we can change molecular weight, length, backbone structure, side chains, and crystallinity. These are the main polymers, PEG, PCL, PLA, and PGA. And this is very suitable for protein molecules, large molecules. I'm going to show you some data of intravitreal delivery of proteins. Proteins, one of the problems is the stability. So we always took care of, if you look at all these interfaces, we have to be very careful. Detergents, organic interface can denature the proteins. Yeah, we do not want to use PLGA because it produces high amounts of lactic acid and glycolic acid, which can cause some irritation. And also PLGA produces burst release. And so our polymers are, you can see that there's a PEG in the central and PGA-PCL. This is a very small amount, only 300 molecular weights. Most of it is coming from PEG and PCL. And then if you want to make it more hydrophobic, you increase the PCL number because this is a hydrophobic polymer. I'm going to be done in 2 minutes. And you can see that if you look just the nanoparticle, you can see that still you get a very high burst effect, 30 to 40%, and then you get a constant zero-order delivery over a longer period. This is 40 days. And again, you can say that this is the IgG using a large molecule, immunoglobulin G, full length. And you can see that what we did is this with the burst, with just nanoparticles. But when we have a gel, which is a thermosensitive gel, which is liquid at room temperature, you can inject it easily into intravitreal space through a 27-gauge needle. But what happens when it is a gel structure around the nanoparticles, you're going to see there is, because of that, the another layer, we don't have that much burst effect. So it releases from zero time, zero concentration, all the way in a nice linear fashion. And we have now gone into up to 4 months, and it keeps going at the same rate of release over that time period. And you can say that this does not, with ELISA and BCA acid, does not lose any activity because of this polymer. And we did the tolerability studies, and we can show you that this is when you inject it into the vitreous, it forms a sac. And the sac contains the nanoparticles. So you do not have any floaters in the eye. It stays in the pocket. And as you can see, as time goes on, 21 days, you can see that that becomes thinner. And then it starts to disintegrate at 42 and 49, pretty much it's gone. So we can engineer this polymer to see that this is a biodegradable, biocompatible, and it goes away in about 3 to 4 months, and it releases the drug in the vitreous at a constant period, constant level. And again, same thing is nanoparticles. If you just inject nanoparticles, it's going to disperse in the vitreous cavity, and it is going to be giving some floaters. So in order to prevent that, you put the nanoparticles in the sac. It doesn't go out. It just stays inside the sac. It goes into the bottom of the vitreous, and it does not cause any impedance in the vitreal cavity or vitreal. And you can see that the polymer tolerability, where we did various mechanisms, and they're very well tolerable. And this is called Hackett-Macdonald score. So this score goes up to 12, and we're way below, even much lower than restices. So the conclusion is that we can use the thermosensitive gel to prolong the sustained release of drugs at the target site. And you can have nanoparticles suspended in a gel, is a thermosensitive gel, could minimize burst release of drugs, and the dual phase polymeric system is much better. And you have a biocompatible gel phase and a discontinuous particle and nanoparticle phase. So such technology can prolong action of the drug and thereby eliminating the need for repeated administration. And this patent has also been issued. So we have two technologies, one for the front of the eye drops, for back of the eye delivery, and also another intravitreal. That I think is suitable for proteins and other macromolecules like siRNA for delivery for long-term injection, one injection for 4 to 6 months. I think that it is very needed, it is timely, and we think from drug delivery point of view, we should be able to do it, deliver it. Thank you all your attention.
So could you comment on the shelf stability, because this is it's a biodegradable block copolymer, and you are in aqueous gel, right? Could you comment on, as a product, shelf life is very important. So could you comment on that?
Yes. What we did is the formulation is like the way the nanoparticles is going to be separate. There will be the syringe will have two chambers. One chamber will have the freeze-dried nanoparticles, and another will have the aqueous solution with everything else. The polymer, the gelling polymer is all soluble. And so once you push them together, then it forms this nice thin kind of a suspension, and it's nano size, so you'll not see much. It's kind of clear solution. And then you disperse it and immediately inject it into the vitreous. So this will be kept at a single injection, dual chamber. It mixed at the time and then injected. Thank you. Other questions?
One other question. So have you evaluated whether the biological activity of the antibody is maintained?
Yeah, only thing that I can show you this, we have the data on, when we were measuring by two different assays, micro-BCA assay, which gives you actually structural information, but then we did the ELISA, which is a biological assay, antibody assay, so it is about the activity. So you look at that, the numbers are pretty close. So that shows that the chemical-based assays, the biological assay, they're pretty much similar, so activity is retained.
Okay.
Yes.
One more question.
Excellent presentation, excellent idea. I wanted to know, when you inject the polymer in the vitreous at nano level, do you induce an RD there? Because you will be separating the posterior vitreous from the retina at that point.
So you mean
the physical presence of even the nano molecule there,
right,
at the level of the, you're going beyond the choroid and retina at the vitreous level, at that interface, can it induce an RD? Have you checked it in vivo?
Yeah, we checked it in vivo in a rabbit model, and we did not see that. And it was examined by many veterinary pathologists.
Ophthalmologist.
Ophthalmologist. And they found no rupture on that, no. So far. But it has not been done in humans, so I don't. Yeah, there's a possibility. Yeah.
What is the reason of using micelles rather than liposomes? What is the advantage?
Yeah, micelles will give you much more the aqueous solution, where a liposome has a lot of lipid in it, and it is not able to carry as much drug as this will solubilize. If you put in liposomes, your dexamethasone or cyclosporin, it is not going to be solubilized, and it's going to be precipitating once you put it into the aqueous drops. So that's why it's not very effective in delivering drugs into the glands and the posterior segment of the eye.
Thank you. Thanks.